So, you know, you get trained in a discipline, and you get taught a lot of stuff that relates to your discipline. So when I went to nursing school, I learned about nursing, and I learned about nursing theory, which I don't know if you disliked it as much as I did, but it was very painful. But there's a whole body of knowledge that sort of trains you in how you should work with people and how you should treat people as the profession that you are. And I think that those ways of being trained really affect how you approach people that you're going to work with. I know that because I'm a nurse, that I'm much more comfortable thinking about medications than maybe other people. And sometimes I really have to step back and say, well, are meds really the answer to this problem, or is there maybe something else that we could do? So your training is going to affect your approach. What kinds of modalities do people in this room use? Is anybody trained in cognitive behavior therapy? Okay. Anybody in psychodynamic therapy? Okay. How about motivational interviewing? Okay. Acceptance and commitment therapy? Okay. Anyone trained in psych rehab? Okay. So again, you know, sort of some people in, what did I miss? There have to be some things that I'm missing. Anybody trained in anything else that I didn't ask about? Oh, it's okay. Occupational therapist. Okay, okay. That's actually a really good field for psych as well. I mean, very helpful. So, you know, people get trained in specific schools of working with people, and that, again, is going to really affect how do you see people, how do you define their problems, how do you approach treatment, and how do you approach treatment planning. So that's a little bit of, you know, sort of, I think, what we bring with us to the relationship. And then I think that part of what defines how the relationship is going to develop is what is our view of the people that we're working with. And again, this is going to be a little bit determined by how we were educated. And, you know, I was educated back, I don't know, that like in the early 70s, okay? And so we knew what caused schizophrenia at that point. We don't anymore. But at that point it was mothers, and there was like this whole, you know, thing around how mothers cause schizophrenia, which is absolutely not true. But being trained that way, it will affect sort of how you view someone with the illness and how you view their family. So I think that a lot of us have been trained in a Kraepelinian perspective, where you view schizophrenia as an illness where somebody is going to go downhill progressively. And that obviously is a disadvantage for a practitioner to have as a belief when they're approaching a person that they want to work with. If you think that they're never going to be as good in 10 years as they are today, you're less likely to look for goals that are going to help them to move forward. You're more likely to say, oh, well, that's the best they can ever do. Let's just, leave well enough alone, let them sit on the couch and smoke a cigarette. And you contrast that with a recovery-focused approach, where what you're really looking for is a way to get this person to be able to reclaim their life. And those two approaches are so different. Now, a lot of what Aaron Beck has said is that he thinks that our problem with working with people with schizophrenia is not the schizophrenia. It's our attitudes. It's the fact that we look at them and we say, this is not hopeless. I mean, it's not a hopeful situation. It's not going to get better. And so we tend not to try. And they've actually, he wrote an excellent book on schizophrenia, and working with people with schizophrenia that I would highly recommend to anyone who's interested in it. And he really sort of outlined things that you could do to be helpful. And those kinds of things can make a big difference. So I think, we look at what we bring and our attitudes, and as professionals, all of us went into this not because it was the way we could make the most money, but we went in because we wanted to help people that we worked with to reach their goals. We wanted to improve people's quality of life. We wanted to help people recover. And it's really important that this concept of hope and recovery live in everything that we do with people, because it's going to help them to move forward. So recovery. I am just briefly going to go through this because I think you've probably had it in a couple of other things, and we're cutting down a little bit on the time here. It's widely valued. Everybody loves it. Everybody loves to think about it, but it's been very difficult to operationalize, and this has happened particularly at a systems level. A lot of states went through and just sort of renamed programs as recovery programs without actually changing anything that was happening inside those programs, and that's a problem. So what we want to see happen in recovery is that people move from feeling despair to feeling hope, and that they move from denial to understanding and acceptance. That they move from passive coping to a more active coping style. That they move from seeing themselves as damaged and disabled to having a more whole sense of themselves. And that they don't feel alienated, but that they feel they have a sense of meaning and a sense of purpose. Okay. So, recovery, we've talked a little bit about, sort of what that looks like. And it generally is a process where somebody moves from being very disturbed, very troubled by the fact that they have this illness, into feeling more like they have some control, they have some ability to manage. And I really like this quote, and I do want to share it. The term self-direction, person-centered, and hope. And these are 3 of the SAMHSA criteria for recovery programs. Suggests that the final arbiter of whether recovery is occurring is the person who is experiencing the recovery. So it really does need to be person-centered in the sense that people need to reach their goals, not your goals. And being trained as a nurse, that's been difficult for me more than once, I must say. So the first thing that you want to do in working with somebody is really to concentrate on the relationship. And this is something that I think all of us got in our training. How do you connect with somebody? How do you start to work with somebody? How are you going to be a helping person? And engagement is recently being looked at as even more important to treatment than some of the things that we do. Because people, if they feel like they have a good relationship with you, they're going to keep talking to you until you finally get it. So engagement is what makes people feel like they're an active part of the process of treatment, and it makes them feel like you're working with them to accomplish something. So does anybody here have trouble sort of establishing relationships with people with schizophrenia? Sitting down and talking, trying to decide what goals are? Yeah? I think some of the things that are common are, they feel like they're fine, they are in denial, I don't quite understand how they're talking and they scare me a little bit. And so I think that it's really sort of important to have some sort of structure for approaching people, and have a structure that's not going to like turn them away. So as far as denial, I'd like to just get up on my soapbox for a minute, because I really think that denial is pretty normal. You know, when I was in my 20s, somebody told me that I had high blood pressure and that I should start medications. I said, no, I shouldn't, you know. And so I spent the next year going around trying to find something that I could do rather than taking blood pressure medicines so that I could control my hypertension. I joined a gym and I exercised and I, you know, cut out salt, and I went to an acupuncturist, and I went to see a Chinese medicine doctor, and the Chinese medicine doctor said, well, I guess I could give you something to bring your blood pressure down, but why don't you just take medicines? I said, well, because I don't want to. I'm young. You know, I should be able to do this. And I think that that's sort of the way that people of, you know, in their early adult years approach chronic illnesses. Who would want to have that? You want to try and rule out every other possibility before you say, okay, you know, this is a problem. So generally, I think we need to find approaches that help people to work on what their problem is, however that's defined. And that it's not necessary for them to say, I have schizophrenia or I have bipolar disorder in order for treatment to proceed. So CBT and CBT for psychosis are two modalities that really fit very well with recovery. You know, like I said, they developed on separate paths, but they really can be used together. And you know, by identifying CBT techniques that can help people to reduce symptoms, you can help them to recover. You find that this is useful with or without medications, but I think the way that I've seen it used most often is that you can help people to reduce symptoms so that they need less medication. Or you can teach them ways that they can respond to stress before they try medication, and that can sort of help somebody to manage their illness, to learn some things that are non-medication based. CBT for psychosis and CBT can increase a sense of well-being. It can increase personal growth. It helps people to develop positive relations and to feel a sense of purpose. You know, I think that it's basically something that helps somebody to think in a way that's going to make them feel better. So when we look at CBT, we know that the way that a person thinks is going to affect how they feel emotionally. You know, so whether they feel sad, angry, and it's going to affect how they feel physically, you know, whether they feel like a stomach ache, a headache, what they do, how they behave. Okay, so, and that's apart from the situation that's occurring, okay? So if you're walking down the street and your best friend, Okay, let's say, well, no, the driving example won't work either. Okay, so let's say you're walking down the street and your best friend walks by and doesn't say anything to you. There's two ways of thinking about this. You can think, oh, she must be really mad at me, she's so angry. Well, actually, three ways. You could say, oh, she's having such a hard time, she's probably too preoccupied, I should probably call her up. Or you could say, oh, maybe she's just, you know, like really in a rush and she has to go to the bathroom and she's running someplace. So the way that you think, the way that you behave, you know, in the first situation where you think she's angry at me, you might avoid her. In the second situation where you think, oh, she's having a terrible time, you might call her up. In this third situation, you'd probably just do what you would usually do and figure, well, you know, hope she made it. Okay, so with CBT, you know, potential outcomes that you're going to look at are that people are able to identify ways to access support, that they're more willing or comfortable or able to interact with other people, that they're able to be successful with specific tasks, and that they feel more normal. And feeling normal doesn't necessarily mean that you don't feel like there's a problem or you don't feel like you have an illness, but it means you don't feel like you're the only one. So all of these potential outcomes are clearly things that are applicable to recovery. These are things that can make people feel like they are reclaiming their life. So CBT for psychosis is actually an offshoot of CBT, and it's been well established as an approach for positive symptoms. It is useful in decreasing hallucinations, it's useful in decreasing delusions, it's useful in helping people to tolerate hallucinations and delusions if they aren't able to eradicate them. So CBTP is helpful for people who don't respond to meds or who respond imperfectly to meds. So one of the things that we do that's similar to CBT for anything else is that we look at the evidence. You know, when people are thinking, those thoughts are often automatic. And you tend to feel like your thoughts are the truth, even if they really aren't necessarily the truth. And the thoughts that you pay attention to, or the explanations that you pay attention to, or the things that fit with your view of the world. So for instance, if you have somebody who's had a psychotic episode, one of the things that they might think is that my friends aren't going to want to talk to me. And then they tend to pay attention to that thought, and that tends to make them feel a certain way, and it tends to make them avoid calling somebody and saying, would you like to go get a cup of coffee? If people are anxious, what happens is they tend to overestimate the risk. So you've got your antenna out for bad things that might happen, and you tend to underestimate your coping ability. So, really high risk, higher than probably is likely, and there's really nothing that I can do about it. If you're feeling depressed, you tend to predict catastrophes. Everything's going to go wrong, everything's always going to go wrong, I'm never going to feel better. And you tend to underestimate your coping abilities. So, what you do in a CBT framework is to look at evidence that supports or does not support your thoughts. People, I did a lot of work with caregivers who had children with very serious disabilities. And one of the things that they would say to themselves quite frequently was, I'm not a good mother. And then, you could have them list all the things that they did for their child during the day. And you'd say, well, how would a good mother be different? How would a good mother be different from somebody who gets up 4 times at night when their child is having a seizure? So there's ways that you can sort of look at evidence that helps to sort of make them question those thoughts. And once you start to question your thoughts, then you really can sort of start to move forward. Normalizing is a really important part of CBT as well, and I think particularly in people with psychosis, that psychoeducation at its best is a way of normalizing. It's saying, I know this well enough that I have a paper about it. Lots of people go through this. There's going to be some differences with you, but we know what to do. We can help you. And so many people feel like they're the only one. and it really is quite relieving for them when they figure out that there are other people who have had these problems and who have been successful with these problems. One of the reasons why normalizing is so important, we talked a lot about stigma in society this morning, but one of the things that we didn't talk about was the fact that everybody who becomes psychotic has grown up in that society with those beliefs. So when people experience these illnesses and when they're diagnosed, they have those same beliefs about people with mental illness. And it sort of makes you understand why they would want to deny it. Who would want to be, useless, lazy, whatever beliefs people have. But we know they're not generally good. So this is a way that you can sort of help people to realize that this is not something shameful about oneself. Often when I start working with people, I'll do a timeline with them. And I think that people don't really have a clear sense of sort of what happened to bring me to this place. And sometimes when you go through, like, looking at all the good things that have happened and all the bad things that have happened, that it really sort of helps you to discover, why are they in this place at this time? What was it about, somebody moving a baby into the house that reminded you of something that was traumatic for you? Or what was it about you having a miscarriage that made you, have this particular reaction? So you can go through the timeline, sort of the sequence of how did people get to this place, and you can offer some explanations. There are a lot of things that really go into staying healthy, and when you talk to people who are having their first episode, they aren't sleeping, they aren't eating, they don't want to eat because they think things are poisoned, they're smoking pot because they think it's going to help them relax, which is actually the exact wrong thing to do because it really aggravates the psychosis in ways that is very unhelpful. The other thing that's really good about the timeline, though, is that you can identify strengths and stressors. So you can start to look at, what does this person have that's going to help them to move forward in this situation? And you can also look at what kinds of things have happened that we want to, look for ways to manage in the future. So it gives you an explanation, and people love explanations. It helps them to figure out that once you have a map, you sort of feel like you can get to where you want to go. So establishing goals for treatment, I think that often people will come into our offices and they'll say, well, my goal is I want to have a car. And you'll say, no, your goal is that you want to have a bicycle. Think about it. A bicycle is so much better. A bicycle is cheaper, and you don't have to have gas for it, and yours is still pretty sick, so you don't want to make that big investment. And they say, no, you don't get it. I really want to have a car. So rather than try and fight with them, wouldn't it be better to say, well, yeah, that's a great goal, So how would you get the money for a car? Well, I'd have to get a job. Well, how are you going to get to work? So ultimately, the person may decide that a bicycle is acceptable. They might opt for the buses, but they might decide that a bicycle or a motorcycle is a first step towards getting a car. So I think that you always want to sort of start with what does this person want and how can I be helpful for them in moving towards their goal. And that if you stay optimistic, that you're gonna actually get further along than if you try and fight with somebody about, no, this is inappropriate, let's pick an appropriate goal. So you talk with people about what are their first steps. And people often can, I had a young guy who wanted to be a scientist and clearly was having a lot of cognitive difficulties, but he found a job in a bench lab. And he loved this job, and they loved him. And, in fact, in the first week, he managed to ruin the whole week's worth of samples that they were working on because he was trying to work really fast, and they said, no, just slow down. You're doing fine. All you have to do is try and make sure that the samples stay, viable. You don't want to break things. So, it was something that then gave him some confidence, and it gave him some joy because he was connected to the field that he wanted to be connected to. You also want to talk with people about their goals with what might get in the way, like with the car. The fact that you don't have a driver's license, the fact that you don't have a job, all of those things might be obstacles. So, how will you know if things are not, if you need to put in some steps before that? You also want to talk about how are we going to tell if it's working or if it's not working. Goals are by necessity have to be fluid. If it's working, you keep doing it. If it's not working, you want to just sort of back off and, try something else. So another thing that you'll do in CBT are behavioral experiments. And this is, getting somebody to try out something that may give them an idea of whether their beliefs are accurate or whether their beliefs maybe are not the best. If you, people will say things to you that you don't know. They may be true, they may not be true. So a young woman said to me, well, if I went to my church gathering, no one would talk to me. I said, well, would you be willing to try that out? And we talked a little bit about what it would be like if she went and nobody did talk to her, but she ultimately decided that maybe they would because she'd seen a lot of people talking to each other and they might talk to her. And she went, and in fact somebody did talk to her, and in fact she kept talking to this person for a period of several months. And when we finished treatment, she actually asked this person if she would agree to have coffee with her once a month so that they could sort of talk about how things were going for both of them, so that they could be a support for each other. Somebody else said, people know what I'm thinking. If I go to a baseball game, everybody there can feel what I'm thinking, and they know immediately what I'm thinking. So you say, well, why don't you, how could we check this out? What if you went there and what if you told like the funniest joke in your head that you've ever heard? And then you could look around and you could see what proportion of people are laughing, and what proportion would let you know that all people can tell you, can tell what you're thinking. So you're able to sort of set things up so that people can try out some of these beliefs that really sort of cripple them. And that is not nearly enough, but it gives you an idea of some of the potential of this modality. Okay, motivational interviewing is another wonderful thing that you can use to promote recovery. It's helpful basically, by definition, in working with people with an uncertain commitment to treatment. So anybody who's in denial, this is perfect. Anybody who says, I just really like the cigarettes, I'm not sure I'm ready to, this is the approach for you, okay? So it's used in healthcare to try and help people to make positive changes that are going to promote their health. And it's helpful in clarifying goals. And with motivational interviewing, what they really say is that so often we approach people sort of trying to educate them into behavior change. And people are stubborn. If you say, you must do this, I was telling the last group, I've been resisting my doctor for 10 years while he's been telling me, you must lose weight. It's like, yeah, watch me. So motivational interviewing is a much more gentle way of talking about it that doesn't get somebody's back up and actually lets them look at, well, maybe I should. Maybe there's something I could do. Maybe it's not like the whole thing, but maybe there's something. So with motivational interviewing, the important things that you want to keep in mind is that you want to really be empathetic. Okay? There is no such thing as too much empathy in motivational interviewing. You want to try and look at what the discrepancies are. You know, you want to be a better father, and yet you're, you know, drinking so heavily that you can't go to your son's, you know, games in the evening. You want to avoid argument and direct confrontation. So you really don't tell people that they're wrong. You don't, no matter how much you want to. So you roll with resistance, okay? If people are saying, I'm not ready for this, you say, okay, you know, it sounds like you really, this just really isn't the thing for you right now. And sometimes what will happen then is they'll say, but wait a minute, you know, because there's a real tendency for people to have, when they're ambivalent, as most people are about a behavior change, they have the pros and they have the cons. So if you're talking about the cons, they're going to talk about the pros. It's like, wait a minute, I really do need to do that. You say, oh, well, you know, if you really need to, let me know how I can be helpful. Okay. And you do this through open-ended statements, so you do it through asking people things that allows them to tell you their thoughts and their feelings about behavior change. You do affirming statements, and this would be, you know, things that help them to feel like they have some control, like they have some ability to decide, like they have the capacity to decide what the best path for them is. You reflect what they're saying, and then you sort of summarize everything so that they have, you know, an idea of sort of the whole picture. Motivational interviewing in people with serious mental illness is helpful, I think, in a couple of ways. The first is to help someone to engage in treatment or to consider medications. Medications are a very difficult topic, and, you know, often by being a little bit gentler about how they might be useful, what some of the drawbacks would be, it's possible to have somebody decide that they're going to take them. It's also helpful in, you know, helping somebody to decide that they're going to go into treatment. And it's helpful in helping someone to make changes in their behavior that's going to improve their physical health, which is a huge problem for people with psychiatric serious mental illness. Now, just in the last couple of minutes, I mean seriously, distress tolerance and stress management. Okay, so stress, we know that stress aggravates psychotic symptoms, it activates negative self-statements, and it can lead the person to feel like they are out of control and there's not too much that they can do. Now, the other thing we know about stress is that it's part of everybody's daily life. So it's really important that people learn a way to manage stress and that they also learn how to avoid avoidable stress, you know. Cognitive ways of managing stress would be reframing things or decatastrophizing things. If you hear somebody saying, oh, I can't do this, you know, I could never go back to school, that's not necessarily something that's true. And sometimes, you know, if people are able to give themselves different messages, you know, it would be hard to go back to school. But I've done lots of hard things in my life. That can be just a way of helping them to see something as possible rather than impossible. And we know that once people have hope, that they can do a lot more than anyone could predict. Then there are more behavioral ways of helping people to cope. Meditation is one. Progressive muscle relaxation, and there are a lot of sort of formats for this on the internet that you can find, but just sort of tensing and relaxing muscles, going down through your body and focusing on your breathing as a way of sort of de-stressing. For people who are unable to tolerate that, and there are a number of people who become more anxious when you do muscle relaxation, you can do grounding techniques where you actually have them pay attention to their environment. So like in this room, I'd have people count the lights and feel the cover of the chair, and then move their hand and notice the difference in the temperature. So you help people to occupy their mind, and then to occupy sort of their physical sensations, and then you do some soothing things like favorite places, favorite days, favorite holidays, favorite time of day, that really help people to focus on something other than the stress, and generally it just gives them a couple of minutes to change the channel. And what's really nice about all of these things is that it does allow people to change the channel, and that gives them a way that they can feel more in control of managing stress and managing symptoms. Okay, so these modalities are going to help people to increase their stability through symptom management, and you can also work with people to identify, signs of relapse and how to respond to those early so that they don't get into too much trouble. So in summary, we know that recovery is our goal, that we have many tools that help with that, and that they can work together. Thank you.